Welcome back, clinical problem solvers. During a busy ED shift, we were in the middle of draining a large knee effusion when the nurse interrupted with the critical point of care potassium of 7.9 milliequivalents per liter. The rest of the panel made it immediately concerning: sodium 128, bicarb 12, creatinine 9, reframing this as life-threatening hyperkalemia in the setting of kidney failure. We split roles. Robbie stayed in the room to maintain sterility and finish managing the knee, while I stepped away to address the hyperkalemia. The patient with this critical lab was a 76-year-old with end-stage renal disease on dialysis who had missed 2 sessions because of severe right knee pain and swelling. She appeared clinically stable, but is that reassuring in the setting of hyperkalemia? No. Today our focus is management of hyperkalemic emergency.
Laying out the art of deduction, it's RLR.
This content is for educational purposes only and is not intended as medical advice or substitute for clinical judgment. Before jumping into the management of hyperkalemic emergency, we want to give you a mental map. Hyperkalemia is one of those problems where everyone remembers what to give, but far fewer people remember the order and the logic behind our interventions. If you understand this framework, everything that follows will make sense. One side of the picture is what we wish we could always do: targeted, definitive therapy. If the potassium is high because the kidneys aren't clearing it, the real treatment is fixing the kidneys. That means fluids when the patient is hypovolemic, diuretics when the patient is hypervolemic, relieving obstruction when the patient has urinary retention, and always holding offending medications. And never forget, reduce the potassium intake. This approach is definitive, it's durable, and it's always the goal. The problem is that when potassium is severely elevated, especially above 6, we often don't have the luxury of waiting. That's when immediate action matters, and the most important medication in that moment is what? Calcium, often in the form of calcium gluconate, because most patients don't have a central line for calcium chloride. Calcium doesn't lower the potassium, it protects the heart. This is not optional when we're worried about hyperkalemic emergency. And worry doesn't just mean any elevated potassium. We worry at any level when there are symptoms such as weakness or EKG changes. We worry when potassium is markedly elevated, like above 6 milliequivalents per liter. And we worry even at lower levels, like 5.5, when kidney injury is combined with ongoing potassium release, like rhabdomyolysis, tumor lysis, and massive hemolysis. Those are the patients who can decompensate quickly. In hyperkalemia, elevated extracellular potassium reduces the transmembrane potassium gradient because you have more intracellular potassium, leading to partial depolarization of cardiac myocytes. This depolarization inactivates fast sodium channels, leaving fewer available for conduction. Because sodium influx is what fully depolarizes the cell, enables contraction, this results in slowed conduction, malignant arrhythmias, and skeletal muscle weakness. Calcium doesn't lower potassium, but it counters this effect by stabilizing the cardiac membrane. By improving sodium channel availability during depolarization, calcium restores conduction and reduces electrical instability, even while potassium levels remain elevated. And when you label someone as having hyperkalemic emergency and you're reaching for calcium, then you're simultaneously throwing the kitchen sink at management of the hyperkalemia. Alongside cardiac stabilization are the therapies we use to buy time. These are supportive measures, sometimes life-saving, sometimes risky, and always temporary. One category focuses on blind elimination, getting potassium out of the body through urine or stool. This can work, but it doesn't address why potassium is high in the first place. It's not definitive targeted therapy. Renal elimination is the most effective approach when the kidneys are functioning. It's faster because we're giving therapy intravenously, and under normal conditions, the kidneys are the primary way the body maintains potassium homeostasis. Gastrointestinal elimination is effective as well. Another category focuses on shifting potassium into cells, and the main tool we use is insulin. Insulin lowers serum potassium by about 1 milliequivalents per liter and starts working within 30 minutes and is temporary rather than definitive. It is always given with glucose unless the patient is already hyperglycemic, like a glucose above 250. We would prioritize this immediately after calcium gluconate. We use IV regular insulin, not subcutaneous, to achieve a rapid and predictable effect. And because hypoglycemia is the real risk occurring in up to 20% of patients, especially those with kidney disease, you need to monitor the point of care glucose hourly for at least 5 hours, the half-life of insulin. I've made that mistake before, but that's a lesson for another day. Here's the principle to hold on to. Supportive therapies are not treatment. They are bridges until you fix the underlying problem, which in our patient was the need for dialysis. We treated the hyperkalemia in parallel with continued evaluation of the knee. Calcium gluconate was given first, followed by an AMP of D50 and IV insulin, Lokelma and IV Bumex, while repeating the potassium and calling nephrology early with the expectation that dialysis might urgently be required. Her repeat potassium, thankfully, was 5.4, allowing nephrology to defer emergent dialysis until the next scheduled run. The knee aspiration confirmed gout, so we treated with an intra-articular steroid injection without empiric antibiotics, as we weren't concerned for a septic joint, and she underwent dialysis the following day with an anticipated discharge soon after.
That's a wrap, folks.
And here's a special mnemonic for the management of hyperkalemic emergency. 1 important C, calcium gluconate, and 4 Ds, followed by a 50 dialysis if all else fails. Diet, referring to both food and medications, dextrose and insulin IV, diuretics, if the patient's making any urine at all, and diarrhea, really alluding to GI cation exchangers. And remember this, study a little more today so you're better tomorrow than you were yesterday.